I'm Dr. Isha Rastogi, Professor in Dentistry Department, Dr. KNS Mims Barabanki, Uttar Pradesh, India. Today I'm presenting uh, on topic Aesthetic Dentistry and Prosthodontics, including restorative materials review. Introduction. Everyone wants to be attractive.
Doctor, would it be possible if you put your presentation in full screen?
Yes, ma'am. Sure, ma'am.
It's the icon on your right, the last one next to the percentages.
Okay.
Yes. Thank you.
This was my first slide. Now I'm starting. Introduction. Everyone wants to be attractive. The Oxford English Dictionary, OED, defines aesthetics as concerned with beauty or the appreciation of beauty. Dental aesthetics is the application of the principles of aesthetics for natural or artificial teeth and restorations like smile designing, facial symmetry, golden ratio, gingival angle, that is GA, and gingival zenith angle, GZA. Now, aesthetics in complete denture. 3D printed complete dentures, CDs, had better color stability compared to PMMA, that is polymer methyl methacrylic monomer CDs. Also, it is seen that nano-filled hybrid denture teeth had lifelike translucency, strength, high abrasion resistance, color stability, resistance, and biocompatibility. Now, since we're talking about aesthetics or natural looking beauty, we are going to be more emphasizing on how in dentistry we can give patient lifelike aesthetics or looks. So these are some materials that we are discussing. Now, these teeth create a natural appearance as physical optical characteristics, and they had less deviation, that is high precision, than conventional acrylic denture teeth. So definitely they have more lifelike natural aesthetics. So it's good for the patient. These are pink aesthetics. Polymethyl methacrylic revolutionized the field of denture-based materials in 1937. Pink aesthetics, as it's called in complete denture, it deals with the replication of these gingival contours and the various aspects of gingiva such as stippling, staining, and pigmentation, so as to give it a more natural look. And here we can see metal-free clasps are being given in removable partial dentures. Now, aesthetics in RPD or removable partial dentures. It is seen that Kennedy's class 4 partial edentulous cases, common in age group above 60 years and most common in mandibular arch. Using aesthetic substitutes to conventional metallic clasp, E-class design, twin clasp, spring clasp, saddle lock clasp, or hidden clasp and metal-free clasp are more good and suitable for the patients for lifelike looks or aesthetics. Then aesthetics in FPD or fixed partial denture, where we have more digital systems coming up like CAD/CAM, that is computer-aided design and computer-aided mechanics, in which we have systems which have increased popularity of ceramics to a great extent. All ceramic restorations result in ceramic chipping, causing fracture over the time. Now, zirconia and reinforced ceramics have proved to be able to withstand for long time without any complaints. So that is definitely the best option. Yeah, the cost is there, but lifelike aesthetics is there. So it is natural mimicking the patient's own looks. Also for ceramic, especially densely sintered zirconia and reinforced glass ceramics have promising future as it satisfies both the prosthodontist and the patient. Now there are other more techniques, more methods how we can mimic the natural tooth. They are cosmetic dental veneers. Laminates are common cosmetic procedure for the anterior teeth, that is the front teeth, as we can see. And many studies have shown that 90% survival rate has been achieved in these in 20 years. So that's a good thing, definitely. It has been reported that porcelain veneers have excellent aesthetic outcomes and predictable longevity while composite veneers have good conservative solution but has no durability. So we see that porcelain veneers are definitely choice. Then cosmetic luminaires are there, which are prepless veneers. They are made of ultra-thin laminate instead of porcelain. So this is all that's coming up for the anterior teeth, and it's definitely good for the patient's aesthetics. Then also in a survey, it was seen among composite that veneers and prepless veneers, that is luminaires, people favored permanent treatment modalities and temporary procedures. Now, snap or smile or removable Hollywood smile is a quick way or instant temporary to whiten the teeth and compensates for the missing teeth. We still need reliable scientific studies about it. Also, it is less durable, bulky, and high risk of decay and plaque is there. Now, coming in aesthetics and maxillofacial prosthesis, where we deal with some organs or like the finger, the eye, the nose, the ear, which is missing in the patient. Now here color matching of natural skin is essential and challenging to the maxillofacial prosthodontics because we are trying to match with the skin of the patient. Silicones and acrylic resins and cosmetic dyes are being used. Manual techniques such as side visual trial and error method, which is most commonly used throughout facial spraying processes, is done. It is followed by some tinting, tattooing, and commercial cosmetics so as to match the color of the skin of the patient. Now, aesthetics in implant. Patients want aesthetic look from the implants also. So, aesthetics is now of concern to implantology researchers, as we can see example as precise implant processes, planning by CBCT, intraoral CAM for 3D planning, tissue punch, modified palatal roll technique, teeth removal without flap elevation, papillary generation. These are all some of the procedures. Custom healing abutments, gingival colored porcelain, platform switching, and colored implants as zirconia implants. It depends on patient's pocket also and the choice the patient wants. We can always offer the choices to the patient. Now, smile design. Virtual smile designing is an essential component of the dental procedure and it is multidisciplinary. DSD, which is the digital smile design software, it allows patient smile enhanced by producing a visual treatment plan. Then we have aesthetic restorative materials. Zirconomers are new GIC with strength and toughness of amalgam, no mercury for posterior stress-prone areas. Previously, shade selection and layering was futuristic and patient expectations were diverse. So was aesthetics definition for them. Now, modifications in GICs composition have been tried, like GIC cement, nano ceramics, silica cement, example, zinc-based GIC, hydroxyapatite, and zirconia reinforced GIC are there. These have been tried so as to improve the mechanical properties in the posterior restorations and give good aesthetics to the patient. Then we have some bioactive materials also. GICs have antimicrobial properties. Also reinforced GIC cement has fracture, strength of 140% and total energy release of 440%. Now, GIC incorporating niobium pentoxide augments the mechanical properties, biocompatibility, and bioactivity. This is the classification of GIC where type 1 is luting with powder liquid ratio, particle size, restorative is type 2, and liners and bases type 3. Then the users for anterior restorations, for luting, core buildup, eroded area, for atraumatic restorations, for orthodontics, for as restoration deciduous teeth, and lamination and sandwich technique. Now, recent advances in composites, bioactive composites with antibacterial and remineralizing properties and rechargeable composite and adhesive with long-term calcium orthophosphate release are some recent materials. They have lasting caries inhibition capacity compared previously with composites that led to recurrent caries. Numerous additional antibacterial, antimicrobial, dental composite, and bonding agents are being used. Sentient N is a new tooth-colored material with isomer that acts as shrinkage and stress reliever. Now, unlike composites, Ormokers are acronym for organically modified ceramic technology, and they are apt for alteration as direct aesthetic restorations. Aesthetic posts, they help in restoration of endodontically treated teeth. and their polyethylene fibers give strength to the composite. Then we have ceramic crowns. Metals are substituted by these, but this because of the fracture of the bulk in these, a little difficult. Then we have categories for chair side CAD CAM restorations. Now dentists have used these for decades for intraoral FPD, inlay, onlay, veneer, crown as abutment. So metal alloys as titanium and others are being used, as we can see with the brand name Vita Blocks, Cerac Blocks, IPS Empress, IPS Emax, Lava, Paradigm, Vita, Telio. These are being used. Now, some other resin cements, they have superior tensile, compressive, and fractional strength. They can be used for various dental restorations. The bond strength is affected by pre-treatment measures and steps with the amount of polymerization of this resin cement is there. Is aesthetic resin cement. Then we have ormokers. Their surplus polymerization allows them to cure without any leftover residual monomers that makes it biocompatible with the tissues to a great extent. Compomers, they are combination of traditional composite resins with fluoride releasing properties and bond of GICs. In clinical beneficial amounts, these materials release fluorides and aesthetic materials used for teeth restorations. So these are compomers and ormokers. Then we have ceramics. Now that's they have been used and they have crystalline forms. They have containing crystalline based systems and polycrystalline solids. They are based on processing techniques as powder, liquid, and glass-based system. Glass-based system consists of machinable or pressure blocks, as I had just discussed the brands also. Slurry or computer-assisted dye process systems. Then there's zirconia. It provides aesthetic restorations used in prosthodontics for endodontic post, crown, bridge, also for orthodontic brackets. It's a popular substitute to alumina as a biomaterial. Coming on to conclusion, as we have discussed so many methods and so many materials, so fabrication of dental materials is designed for dental use. Direct restorative materials are compomers, resin fill, modified GIC, resin, amalgam, composite. Indirect restorative materials are gold, ceramic, resin hybrid, resins. Aesthetic and perception of beauty is different for everyone, and it also depends on culture, experience, and serve. Even though ceramics are so characteristic looking, still clinically to assess them in patient mouth as masticatory forces and parafunctional habits may cause failure of ceramics. So in the end, I would just like to say aesthetics is actually a multidisciplinary field, interaction with the dentist, with the patient, with the choice the patient wants and what the pocket or the budget allows of the patient. We can definitely go for aesthetics and satisfy the patient with natural lifelike aesthetics and make the patient happy. I hope you enjoyed my presentation. I thank the management and the team for giving me this honor to present today. Thank you so much. Good day. Namaste.
I'm a plastic surgeon from Sri Lanka. I recently returned from Australia after completing my fellowship there. So I'm very pleased to do this presentation today as one of the first things I do back in home. So this is a sort of plastic surgical topic. As my topic suggests, it's about a novel technique of fingertip reconstruction. It's named as Homodigital unipedicled islanded neurovascular pulp advancement flap. It is self-explanatory in technical terms, but in short form, we named it as Colombo flap because our national hospital, first is the National Hospital of Sri Lanka, which is in Colombo. And this full article you can find in Indian Journal of Plastic Surgery, published late in 2023. If you are interested, you can find the full article there. So, looking into the background of fingertip injuries, it's the most commonest type of upper extremity trauma because it's the extremity that as human beings we use for most of our day-to-day functions, so that it is vulnerable for injury. And quite interestingly, the mechanisms that result in fingertip amputations are thrust mechanism rather than sharp cut injuries, like tapping in doors, tapping in the car door or the door hinge, or in occupations where the machinery involved. So that excludes the possibility of replantation, which requires joining the blood vessels together under microscope because of the crushing mechanism. Otherwise, that is the gold standard management. So in those situations, so we need to think of what the best result we can give both functionally and aesthetically. Some of the injuries can be managed without surgery just by conservative management, which needs series of dressing changes, and it will take usually about 3 to 4 weeks to get it healed by secondary intention. But most of the time, where there is a larger defect or there is exposed bone or there is a fracture in the distal phalanx, it indicates there is a requirement for operative management. So then we have to select out of our toolbox we have what surgery we are going to do. So to decide that, we keep few principles in back of the mind to achieve certain goals. Obviously, preservation of the length and the sensation. Most of the customers or the patients are interested in preserving their length, both for aesthetic reasons and also for the functional reason. A fingertip without sensation is most of the time useless because that's very useful to function properly, especially if we are dealing with some delicate stuff in day-to-day life. And prevention of nail deformity, especially in this context, is the hook nail deformity, what we call that the nail bent forwards on top of the distal most part of the finger, and painful neuromas. That's the one of the other goals. Early return to work is other important factor, and also we have to achieve acceptable cosmetic appearance because nowadays any part of the body is considered aesthetically important, especially for the females. The fingertips are very important. So keeping that on the mind, I'm just going to deep into some of the technical details. This picture is taken from internet. So fingertip amputation, we can describe in certain ways. There are certain many classifications, like Ishikawa, Allen, or Hughes, and also there's a classification of P and B classification, stands for pulp, nail, and bone classification. So I'm going to describe in terms of Allen zone. So the Allen zone 1 is a very distal tip amputation where there is no bone exposure. When it comes to zone 2, the fingertip, the bone is get exposed, where those are not suitable for replantation because there is no blood vessel to connect. When we come to the zone 3, we can do microvascular anastomosis, which stops at the level of the lunula, then starts the zone 4. So if you see an injury like this, so we have to, as I mentioned already, make the surgery. We have many options. So one is the easiest straightforward option is revision amputation, obviously, which will result in a shorter finger. And also most of the cases, you will not have a nail at the end. And other option is skin grafting. As we all know, when we are trying for aesthetic or functional reconstruction, we are trying to replace life with life. So to get the glabrous skin on the pulp, we ideally, at least it should take some skin from the hypothenar region or the palm of the finger to replace the life with life. But you just get a skin graft. You don't have the bulk that the normal pulp will have. So the best option with most of the situation will be doing a flap, which can be a local flap, regional flap, or a free flap. Homodigital flap is we do the flap using the tissues in the same finger, so that avoids the intrusion into other digits, which will damage the other digits for the donor side. And also, if you do a recruit a flap from the other finger, adjacent finger, most of the cases, there will be a period of immobilization before the revision of the flap. So therefore, there will be a secondary procedure. If you do a homodigital flap, most of the time you can avoid these problems. So when we look into the available homodigital flap options, there are many flap options, but the most commonly known one is the Voller VY advancement flap, originally known as the Tranquillary flap, but later now well known as Adipose flap. And also there's a lateral double flap procedure called Cutler flap. And also there's a flap called Venkataswamy flap, which is an oblique triangular flaps, which I will show in the next slide. And also there are flaps, homodigital islander flaps. All of these flaps have some of their own inbuilt problems, mainly the lack of advancement. If you have a larger defect or the amputation is not oriented favorably, like volar oblique type amputations, the limited advancement of the flap is a considerable consideration. And also, most of, if you go through the literature, most of these flaps still have the problems like hook nodal deformity or fault intolerance. This slide shows the homodigital flap options from your left, starting the atasoy flap, and in the middle, on the top, you see the Cutler flap. It's a double V-Y flap. And the oblique triangular Venkatas Masami flap is the lower middle picture. And homodigital island flap is a bit of technically advanced option, but gives a better result. So in this paper we published, we did a study as a prospective study in National Hospital of Colombo from year 2020 to January. And we followed up these patients up to 2.5 years. And we included 5 fingertip injuries of 4 patients. And our inclusion criteria was traumatic single or multiple fingertip injuries. And generally, it is not suitable for reimplantation for like crushing mechanism or breast contamination or other reasons. The proximal Alonso injury, we selected that where there is generally a very little nail bed, like 25 to 30% remaining, so which generally considers not suitable for other flap options. And we excluded thumb injuries and non-consenting patient, and also the multiple comorbid patients, including diabetes and vascular disease, and also smokers. So this, I'm going to now describe the technical details of the surgery. So these pictures depicts how our incisions and the dissection planes. So what we first, this surgery can be done even under wrist block or a finger block, and we need a finger tourniquet at least to get an avascular field. First, we clean, debride the amputation. And since our aim is preservation of the length, so we do a minimal bone debridement, so we preserve the bone length available. And then we make the incision as depicted in the picture on your left side. If you are familiar with the Venkataswamy flap, slight difference is the oblique part of the incision is not going across the distal interphalangeal joint crease. Instead, that is coming more laterally on the mid-lateral line up to the DIPJ. So the long limb runs all along from the wound edge to the proximal interphalangeal joint crease level in the mid-lateral line. The other incision comes on the mid-lateral line up to the DIPJ crease. Then it runs obliquely on the volar aspect up to the PIPJ. And on the right, you see how the plane of the flap elevation, as you see, on the long limb of the incision side, you have to incorporate the neurovascular pedicle in that flap. So you have to carefully dissect the Grayson's ligament and go behind the pedicle and get it into the flap. On the other side, you drop the neurovascular pedicle. So this finally becomes, as topic says, unipedicled flap. Then you place the flap, distal to proximal, so volar to the periosteum, then you have the flexure sheath and the volar plate up to the level of your proximal interphalangeal joint level. Then we have to island the flap. After islanding, if you need more further mobilization to have a better advancement, we can either extend the long limb and get more advancement by releasing the side branches of the pedicle, or even you can use a blunt tool to lift and carefully dissect the side branches and get more advancement. It will be more clear if you focus onto the middle picture on the top, that this is one case we did on 2 fingers. The flap is very islanded and mobilized solely on the pedicle, both containing the nerve and the artery on that side. And as we mentioned in our study, we followed up the patient for 2.5 years, and we measured our outcomes using the standard tools, including MMRC grading for sensation, range of motion using in the both joints, and grip power using standard measures for power grip, key pinch, and the pulp pinch. And we used the Michigan hand questionnaire, translated version into Sinhalese. And also we looked into the complications using the standard tones, which included flap necrosis, infection, scar problems, neuroma, and hook nail deformity using the limb grade, and also pain using numeric pain scale, and also cold intolerance using cold intolerance severity score. So this table shows the demographic characteristics of our patients. As we mentioned, we had 4 patients who had 5 fingertip injuries. And if you focus on the amount of the nail bed left in all of these patients, it was slightly like about 25 to 30%, which will generally hard to achieve a good outcome. And this picture shows one of our cases, 2 cases. So if you see the result, if we focus on the right hand side, which clearly shows very little nail bed is available, but final results is quite satisfying. So if I go and describe this table for you, this shows our outcome measures. As you see, in the table, AF stands for the affected finger and CE stands for contralateral equivalent fingers, which we used as a comparative measure. So they all had quite good results in sensory recovery, everyone achieving S3 plus or S4 in the MMRC grading. And the range of motions also were comparable to the normal finger, except for one patient who was a 69-year-old male patient who had only about 50% of the range of movement in the distal interphalangeal joints, which can be attributed to the age-related arthritic changes. And the power grid key pinch using a chamber dynamometer and pinch gauge and all were comparable to the normal finger at the end of the follow-up period. And as I mentioned, we used Michigan Hand Questionnaire, which has 6 domains. If you see this table, everyone had very good satisfactory outcomes. Every domain has more than 80%, 85% score, and average was around 97%, which shows that the final satisfaction is very much on the person's perspective. And quite interestingly, none of the flap neck closed or dead, and hook nail deformity using the limb grade was acceptable, and none of them had reported any pain, and cold intolerance was 0. That is very important finding in our study. And they all returned to work in 3 to 4 weeks' time, which is quite a good time to reduce the time wasted managing the wound. So as the conclusion, I'm trying to highlight what is unique in our technique. Obviously, it's inspired by many of the previously described techniques, and we focused on avoiding complications or the limitations of those previously described techniques. As I already mentioned, we get more advancement than the conventional adversarial cutler flaps, and even of their modifications. So the usual advancement was about 15 to 17 millimeters at least, which was not seen in any of the other previously described techniques. And one of the important things is using our technique, as you saw already, there will be no scar running from the finger pulp on the volar side, on the pulp region. So having So if you have any scar on the pulp, it's generally considered not only aesthetically not good, but also functionally, a scar will affect the function. So our flap technique doesn't leave any scar on the pulp region, and no scar will cross the joint, so which is, at least theoretically, will avoid any contraction. So that is the modification in our technique. Even the without modification or Morgan modification of previous described flaps couldn't achieve. On top of that, we had very promising outcomes, as I already described. It gives more advancement. Therefore, at the inset of the flap, there will be no or minimal tension of the residual nail bed, edge of the residual nail bed, which in turn, so there will be no hook nail deformity because the nail bed is kept without a tension. And also, they all had near-normal sensory recovery, good strip thins, and good range of movement, and early return to wound, and very high aesthetic and patient satisfaction. So this is our technique. So we have included only 5 cases or 5 fingertip injuries in this publication, but we have so far done many cases, all had very good results. And in some cases, we have combined free nail bed grafting in situations where we had no or very minimal nail bed, even less than 25%. So it can be combined with the free nail grafting if you don't have a residual nail bed left. to deal with. So it and not only so therefore this can be like further progressed, and the technique can be further modified to get a better result. So I invite all of you guys to if you are very happy to adopt this technique in your practice, and if you can give us a feedback on your experience and also do a comparative study, I'm suggesting that will be a good take home from this presentation today in this conference. And these are my references. And thank you very much for giving me this opportunity in this international conference. Thank you.
So let's start. Malaplasty is a plastic surgery procedure that allows for altering the size, shape, and projection of the cheekbones. The surgeon's role is to assist in realize the patient's aesthetic preferences, but how can they guarantee the final outcome? 3D modeling throws a significant aid in surgical planning, yet it does not fully reflect reality. Thus, plastic and orthognatic surgeons must rely on extensive experience to develop the necessary skills for achieving ideal results. The aim of the study was to identify the patterns governing the bony and soft tissue structures in the zygomatic region during reductive and augmentative osteoplasty to modify the volume of the midface. To achieve this, the dynamics of changes in the bony structures of the zygomatic bone and arch during reduction and augmentation malaplasty were evaluated, as well as the nature of changes in the soft tissue covering the intervention area associated with the displacement of bony structures. Sorry. A review of Russian and English literature revealed only 2 studies with numerical data examining bony structure displacement during augmentation malaplasty, one for reduction malaplasty and one photogrammetric study for reduction malaplasty. No studies focusing on the zygomatic region that investigated changes in soft tissue volume were found. However, several studies were found that explored the volumetric relationship between bony and soft tissue structures in jaw surgeries, concluding that great soft tissue displacement occurs in areas where the tissue is thinner. The hypothesis suggests that the soft tissues of the zygomatic region should significantly reflect bony displacement. The study included 16 patients. 9 underwent augmentation of the zygomatic region and 7 underwent reduction. The average age for augmentation malaplasty was 32 years, and for reduction it was 27.4 years. 2 patients who underwent zygomatic reduction did not have the zygomatic arch osteotomized. Their results were analyzed separately. Each patient underwent 3 computed tomography scans postoperatively, immediately postoperatively, and at least 6 months postoperatively. The following method was used to evaluate the target parameters. In the program in vivo dental, 2 CT scans were superimposed. First, postoperative and preoperative, and second, long-term and preoperative. For both superimpositions, an actual slice passing through the zygomatic arch was used. The zygomatic arch was divided into 5 equal segments for both superimpositions, and like 1, 2, 3, 4, 5, 6. And using the ruler 2 in superimposition mode, the difference in the position of homologous bony points was measured for case 1. This reflects the level of bony displacement immediately postoperatively. The relationship between postoperative displacement of the zygomatic convexity and the magnitude of bony displacement at the surgical site was assessed for each of 5 points using the ruler 2 in superimposition mode, the difference in positions of homologous bony points was measured. For case 2, this reflects the level of bony displacement in the long term, denoted as T2. The percentage of relapse in the long term relative to the postoperative result was evaluated, and using the ruler 2 in superimposition mode, the difference in the position of homologous soft tissue points was measured for case 2. This reflects changes in the position of soft tissue structures in long term relative to their preoperative position. The relationship between soft tissue projection and magnitude of bony displacement during surgery was identified, and the dependence of displacement was assessed by performing correlation analysis with scatter plots and linear regression on absolute values in our studio. So, surgical techniques for reduction malaplasty. The procedure was performed using by a combination of two approaches, preauricular and intraoral. A modified preauricular approach was used with the incision made behind the tragus. 45 degrees osteotomy was performed superostally 2 centimeters anterior to the base of the zygomatic arch. In the oral cavity, a wide incision was made along the mucobuccal fold of the oral vestibule, and the zygomatic alveolar crest and zygomatic maxillary suture was visualized, and the periosteum was elevated to the frontal process of the zygomatic bone. 2 parallel cuts were then performed along the inferior lateral orbital rim, starting from the temporal region from the posterior edge of the zygomatic body, obliquely downwards and forwards to the zygomatic maxillary suture. A third cut began at the end of the upper osteotomies and ran parallel to the zygomatic maxillary suture to the attachment site of the masseter muscle. The bone strip between the parallel cuts was removed, creating space for medial and superior displacement of the zygomatic bone. The anterior fragment of the zygomatic arch was displaced immediately relative to the posterior fragment. This achieved significant reduction in the lateral and slight reduction in the anterior projection of the zygomatic bone. What about augmentation malaplasty? The procedure was performed we are in intraoral approach only. After skeletal exposure to converting osteotomies were performed on the bone, horizontal and vertical, like this. The exact positions of the cuts were determined individually for each case based on the desired surgical outcomes, but always followed the L-shaped osteotomy techniques. Rigid fixation was achieved by using Pavlov's frames. You can see them on the picture. What about results of the study? First, let's examine augmentation malaplasty. The magnitude of lateral displacement of the zygomatic bone at the osteotomy site was designed as x1, with each subsequent segments moving away from x1. Designed, let me better show you, that's x1. And then they went like x2, x3, 4, 5, and 7. And the magnitude of anterior displacement was designated as x7. For T1 measurements, the following conclusion was drawn. There is a moderate positive correlation between displacement at point x2 and x7 and intraoperative displacement of the bony segment. Point x2 has displaced by an average of 85% and point x7 by 75%. No correlation was found between displacement at points x3, x4, x5, and intraoperative displacement. Displacement at point x5 was observed in only 3 cases and was minimal. Point x6 remained stable in all cases. The uniction of the zygomatic process of the temporal bone and temporal process of the zygomatic bone will be stable in any case. For T2 measurements, the position of bony structures in the long term changed by from 4 to 45% relative to postoperative measurements, and significant variability was observed in long-term results, which changes in both increased and decreased displacement of bony structures independent of gender or age. These results can be attributed to individual patient characteristic shown in this table. For T2 measurements, the trend of positive correlation between displacement and point x2 and x7 and displacement in point x1 observed in T1 measurements persist. Point x2 was displaced by an average 69% and point x7 by 49%. Thus, in the long-term displacement at point x2 and x7 relative to point x1 constituted a smaller percentage than postoperatively, likely due to osteolytic and osteogenic processes in the zygomatic bone and adjacent structures posteriorly. The correlation for displacement at point x3 and x4 remained insignificant, and displacement at point x5 was noted in only 1 case. Data for soft tissues showed a consistent positive correlation between points M1, M2, and 3, and their corresponding bony points x1, x2, and 3. Point M4 exhibited a weak relation, possibly due to minimal displacement of the underlying bony structures, named X4, and redistribution of soft tissue volume and tension. Parameter M5 changed in only 1 case, so no scatter plot for it. Parameter M6 remained unchanged, and anterior displacement of soft tissues M7 was observed in all patients. In 2 cases, changes in soft tissues positions in the anterior segment depended not only on intraoperative zygomatic displacements, but also on changes in maxillary position during simultaneous maxillary osteotomy. The influence of maxillary displacement on zygomatic soft tissue volume was empirically demonstrated in a study by Peterson. And in 1 such patient, displacement and point M7 was a significant outlier, and this outlier was not included to the calculations. Data showed a high variability at points M2, M3, and M7, likely due to individual anatomical differences. And in augmentation malaplasty, the maximum effect is achieved in the anterior region of the zygomatic osteomy site, points M1, M2, and M7, and becomes negligible moving away from it, reaching 0 at the temporozygomatic sputum. You can see the percentage of the long-term results comparing to the postoperative and minimal and maximum values. About reduction malaplasty, the magnitude of lateral displacement of the zygomatic bone and the body osteotomy site was designed as X1, which with each subsequent segment moving away from X1 designed as X2 and so on. similar to augmentation, and the point at the zygomatic arch osteotomy site was designed as X6. The magnitude of posterior displacement was designed as X7. Correlation analysis for T1 measurements revealed a strong positive correlation between displacement at points X2 and between displacement at points X5 and X6. X2 was displaced relatively to X1 by an average of 77%. X5 was displaced relative to X6 by an average of 100%. It's logical to assume that two osteotomies X1, X6 points provide two reference points for access and displacement in the intervening points. This theory is supported by our findings. Displacement at point X2 depends on displacement at point X1, and displacement at point X6 influences displacement at point X5, and to a lesser extent, point X4 as evidenced by positive correlations. Displacement at point X3 equally depends on displacement at points X1 and X6, preventing significant correlations. For all reduction malaplasty cases, low statistical significance was observed, likely due to the small sample size. Displacement at point X6 evaluated the thickness of the zygomatic arch, and in two reduction malaplasty cases without zygomatic osteotomy, their results resembled those of augmentation malaplasty, as zygomatic displacement was determined by movement at point X1 and the elasticity of zygomatic arch, which remained entirely stable at point X6, but with a negative vector. In augmentation, it was like this, and reduction, it was like this. Where I have stopped wasn't it? I'm sorry. This variant may offer greater predictability and controllability, but this requires validation with a larger sample. Insufficient data precluded scatter plots generation and correlation analysis. In both reduction cases without zygomatic osteotomy, arch osteotomy posterior displacement of the zygomatic bone, point X7, was observed, whereas in reduction malaplasty with osteotomy, posterior displacement was noted in only 1 of 5 cases. This phenomenon may be due to the displacement vector in the two surgical variants. Without zygomatic arch osteotomy, the zygomatic bone reduces its projection by rotating around an axis and the temporozygomatic shooter, thus moving away from its original antero-posterior position. With zygomatic arch osteotomy, the zygomatic bone undergoes inclination and elevation, altering its medial-lateral and vertical position, which may not allow displacement along the anterior-posterior axis. Unfortunately, the degree of soft tissue displacement could not be accessed due to absence of long-term postoperative CT scans for all the reduction cases. So, in conclusion, I can say that soft tissue changes associated with bone structure displacement due augmentation during malaplasty were evaluated. The data demonstrate a consistent positive correlation between M1, M2, M3 and corresponding bony landmarks. No sufficient data were available to access similar patterns for reduction. A correlation was found between bone points displacement and the degree of interoperative movement for augmentation malaplasty. Points closer to the osteotomy site in the zygomatic body showed stronger correlation, and the point at the zygomatic temporal junction remained stable. in all cases. Combined dependence of bone displacement on two intraoperative influence zones was found for reduction malaplasty with arch osteotomy. Points closer to the zygomatic body osteotomy were more affected by body displacement, and points closer to the arch osteotomy were more influenced by arch displacement and depended on its thickness. Results for reduction malaplasty without arch osteotomy resembled those for augmentation malaplasty. And that's the end of my presentation. Thank you all for your attention. That's all.
To cover the multiple gingival recession. So let me just give you a brief about my topic of today's presentation. As the branch of periodontology, it is one of the specialized branch of dentistry, and it is basically a surgical branch that deal with numerous kind of surgeries pertaining to the gums which are carried out. So these surgeries can vary from returning the normal depth of the gums to covering the exposed gum roots. That is the mucogingival surgeries. So talking about the mucogingival surgeries, which were specifically indicated to cover the exposed root of the gums, which in our clinical terminology is known as gingival recession. So out of various kind of mucogingival surgeries, some are meant to cover the exposed root of the single gum, and the other are meant to cover the multiple roots of the gum, just as in today's case. So here, by talking about my presentation, my today's topic is on the mucogingival surgery, that is the coronal repositioning of the gingiva or the flap to cover the multiple exposed root of the gums, that is to cover the multiple gingival recession. Yes, ma'am, please change the slides. Okay, so beginning with the introduction, a long time ago, dated back 180, the dental field was very limited, means the only treatment modality, whether to treat the diseased tooth in terms of class 1 caries, class 2 caries, grade 1 mobility, grade 2 mobility, Miller's class 1 recession, or class 2 recession was extraction. However, over these past few years, dentistry had come so far beyond extraction that extraction can be considered as the last treatment modality. Yes, ma'am, next slide. Over these few years, people have become aware of their dental problem to the point which is of prior concern in terms of point of view is to save the diseased tooth. And which is one of the reasons that dentistry has gone much beyond extraction. Nowadays, beyond extraction, there are various advanced treatment modalities in dentistry that are meant to increase the aesthetic appearance of the tooth as well as to provide a clinical clarity too, such as smile designing, composites, veneers, other restorations, depigmentation, pedicle flap, free gingival grafts are available, which tend to save the tooth instead of extracting them. Yes, ma'am, next slide. So talking about as gingival recession. So in the field of periodontology, four structures are of important concern. That is gingiva, whose main function is the protection of the underlying structures. And these underlying structures are the supporting tissues which hold the teeth in their socket. That is alveolar bone, cementum, and periodontal ligament. Talking in terms of gingiva, so gingiva is the part of oral cavity that covers the alveolar process of the jaws and surrounds the neck of the tooth in a collar-like fashion. Different characteristic features of gingiva are there that gives the gingiva its sole identity. And among them, the most important in the field of periodontology is the position of gingiva. Yes, ma'am, next slide. Ma'am, next slide. Yeah. So talking about the normal position of the gingiva is at the, ma'am, previous slide. So talking about the position of the gingiva, the normal position of the gingiva is at the level of cemento-enamel junction or 1 mm coronal to the cemento-enamel junction. However, this position of gingiva is not stationary as compared to the cemento-enamel junction, which remain constant stationary throughout the life of an individual. So taking into consideration the position of the gingiva can shift more than 1 mm coronal to the cemento-enamel junction. Hence, we get a pathology called as the gingival enlargement, or there can be an apical shifting in the position of gingiva, a condition called. How long back ago, gingival recession had which is defined as the displacement of soft tissue margin apical to cemento-enamel junction with oral exposure of the root surface. Yes, ma'am, next slide. Okay, so now the main important thing that in periodontology, various causes of gingival recession can be there. So let's discuss about the first cause, that is morphology. So in case of morphology, it refers to the thickness or thinness of gingiva. Means a gingival can be of the thick biotype as well as the thin biotype. Talking about the thick gingival biotype, the gingival tissue is not so transparent, it is opaque in such a way so that the underlying roots are not visible promptly. In this gingiva follows the bone thickness, means this gingiva is thick because the underlying bone is thick and hence it resists and recession. Talking about the thin gingival biotype, so thin gingival biotype is identified by the visibility of roots beneath the gingiva. Hence, this thin gingival biotype shows that the bone beneath the gingiva is thin, and such type of thin bone is less resistant to recession and more prone for fenestration and dehiscence. Now coming on to the second cause, that is trauma. So if I brief about the trauma, so it includes the wrong using of brushing technique means, and it includes the aggressive use of toothbrush. As in today's case of presentation, the patient's aggressive habit of toothbrushing was the etiological factor where the wrong way of brushing technique had led to the multiple gingival recession of the left side of the patient. Another traumatic factor which can lead to gingival recession is the habit of keeping the blunt end of the pencil, pen, or fingernail on the gingiva, leading to gingival recession. Now coming on to the third thing, that is the inflammatory periodontal disease, which is the 90% cause of the gingival recession. So it results due to the presence of the main microbial film, that is plaque and calculus, leading to the loss of interdental bone, papillary height in the anterior region of dentition, followed by lateral food impaction in the posterior region of dentition. Yes, ma'am, next slide. Okay, so classification of gingival whose main point were based upon the interdental bone loss, soft tissue loss, and the important landmark which Miller uses in his classification was the mucogingival junction. So if I talk about the class 1 recession, so in this side, there's a recession which does not extend to the mucogingival junction. So there is no soft tissue loss and the interdental bone loss. Class 2 recession is the type of recession where the recession or the root exposed to the mucogingival junction or beyond to it, but there is no soft tissue loss and the interdental bone loss. Class 3, if we talk about, so of course, there's a marginal tissue recession that extends beyond the mucogingival junction, followed by the in which the soft tissue is apical to the cemento-enamel junction, but coronal to the apical extent of the marginal tissue recession. Now coming on to class 4 recession, ma'am, slide please. Yeah. So marginal tissue recession that extend beyond the mucogingival junction, as you can see in case of class 4th image, that is particularly on the left side, on the lower left side, there's a loss of the interdental bone, there's a creation of the black triangles, and the interdental bone has extended to the level which is apical to the extent of margin tissue recession. Now, if we talk about the images explanation, so class 1 gingival recession, as I told you, in this case, there's the gingival recession does not extend to the mucogingival junction. So as we can see in the right side, upper right side of the image, that is class 1 recession, the recession has not extended till the mucogingival junction, and the interdental bone and the soft tissues are at the normal level. Now, if we go to the upper left side of the image, that is class 2. So in case of class 2, the gingival recession is extended till the mucogingival junction, but still the position of the soft tissue and the interdental bone is intact. Now, if we talk about class 3, that is the image present on the right lower side. So the gingival recession has extended beyond the mucogingival junction, but the level of interdental bone and soft tissue is apical to the cemento-enamel junction, but coronal still to the mucogingival. And class 4, there's a severe ma'am, next slide. Okay, so the main scenario of today's presentation, that is the case presentation of this patient. So talking about this patient, a 41 years old male reported to the Department of Pedontology with a chief complaint of hypersensitivity in his upper left back tooth region since 1 month. Upon taking up the clinical history by the patient was systemically healthy and has not undergone prior any dental treatment. Now the extraoral, now coming on to the examination, that is the extraoral one and the intraoral one. So extraoral examination of the patient has revealed that the patient was bilaterally symmetrical. There was no associated fever, loss of appetite, and the lymph nodes were non-particle. Now coming on to the intraoral examination, when we have gone for the intraoral examination, we reveal that the recession was of the class 1 gingival recession, and the area was completely free of plaque. So upon asking about any brushing habit, patient has said yes, he brushes aggressively, very aggressively, and this was the main cause for such type of recession. So in this patient, multiple areas were involved on the maxillary left side. So the decision was taken to do the coronal repositioning of the flap in order to cover the exposed roots. Next slide. Okay, so talking about the incisions. So incisions were given. The first incision was the clavicular incision. That is the incision between the tooth and the gingiva, followed by the oblique incision, which was given in the interdental area, that is between the two tooth gingiva. So till the incision begins from the lateral incisor till the second molar. And in this case, no vertical incisions were given as gingiva was of the thick biotype. So adequate width of attached gingiva was there. Now, next slide. Okay, in the third image, there was a total reflection of the flap with a mucoperiosteal elevator beyond the mucogingival junctions. And as you can see, clearly the exposed bone from this figure. So after a minor debridement, next slide. After a minor next slide. Okay, so the patient come after 1 month for the follow-up, and there was complete coverage with respect to the maxillary posteriors, that is the premolars and molars, and 40% coverage with respect to lateral incisor and canine. In this patient, the complete coverage is achieved after 4 to 6 months only, and the only drawback of this case was that the patient did not turn up for the further follow-ups, so that we cannot say completely about the proper coverage of lateral incisor and canine. Next slide. Okay, post-surgical management, that holds the key to the successful surgical therapy management. Patient was instructed to come for suture removal after 1 week to avoid brushing of the operated area, but there was a need to keep that surgically operated site clean. So the patient was prescribed chlorhexidine mouthwash, that is 0.2%, 10 ml for 2 weeks, followed by the resuming of the gentle toothbrushing with a soft brush after 4 weeks. And the patient was instructed to keep the operated site as much as possible, follow up after 1 month. Ma'am, next slide. Okay, so here, the clinical significance I would like to draw your attention is, since gingival recession is characterized by the exposure of roots, either partially or completely, so this exposed root or roots hold the clinical significance that if these roots or root exposed are not covered by any type of root coverage procedure, then this exposure can lead to sensitivity, hypersensitivity, root caries, as well as if this recession occurs in the anterior region of the maxilla or mandible both, so it can be aesthetically unpleasing. And in some cases, particularly if the recession has extended to the class 3 or class 4, then there's a decreased width of attached gingiva such that we cannot do these type of root coverage too. So early surgical intervention is better rather than going on for the extraction. Ma'am, next slide. So hereby I would like to conclude my today's presentation that recession is one of the characteristic feature of periodontal disease, and there are various patient periodontal status as well as the general health status and should confirm the cause of recession so as to treat it accordingly. Various procedures for root coverage are available. Among them, one is the coronal repositioning of the flap without vertical incision. This flap serves as an excellent predictor for complete root coverage, provided that there is an adequate thickness of the attached gingiva and better suitable if the recession defect involves multiple teeth. If there is not much clinical attachment loss and recession comes under middle class 1 and class 2 recession defect, then this flap holds the excellent indicator for such type of defects. Ma'am, next slide. These are my references. Ma'am, next slide. Okay. Yeah, ma'am, next slide. Thank you so much for your patience listening, and I'm extremely sorry for the trouble. Thank you so much.
Thank you so much, doctor. If anyone has any questions, please turn on your mic.
Greetings to one and all. I'm Dr. Merlin Thomas, hailing from India. I take this opportunity to share few sights on the topic enhancing gingival aesthetics. I'll be giving a brief introduction followed by certain case scenarios and its discussions. In the present era, everybody's expectations on dental health and aesthetic requirements has increased considerably. As a dentist, we emphasize on the periodontal health along with aesthetic appearance. So currently, we aim to focus on leveling of teeth along with display and architecture of apparent gingival tissue, its color, contour, size, shape, phenotype, consistency, surface texture, and zenith position. In healthy periodontium, the color of attached and marginal gingiva is generally coral pink due to vascular supply, the thickness, degree of keratinization of epithelium, and presence of pigment containing cells. The size of gingiva, it corresponds with the sum total of bulk of cellular and intercellular elements and their vascular supply. The contour or shape of gingiva depends on the shape of the teeth and their alignment in the arch, location and size of the area of proximal contact, and also the dimension of facial and lingual embrasure. The consistency, it appears firm and resilient. Now the surface texture of gingiva presents is textured surface which is similar to that of an orange peel. Hence, it is referred to as stippled. The position of gingiva is at the level at which gingival margin is attached to the tooth. Here, we can note that the level of gums is at the level of cemento-enamel junction. This slide represents the classification of periodontal diseases and conditions. So, alterations in earlier discussed healthy periodontium occurs in conditions such as gingivitis, periodontitis, or other conditions affecting the periodontium. Now let's see few scenarios where gingival aesthetics comes into play. A 22-year-old female patient who is systemically healthy reported with a chief complaint of dark gums. On clinical examination, we analyze the pigmentation as part of physiological process such as melanin, melanode, and keratin. Hence, a periodontal plastic procedure, that is gingival depigmentation, was carried out. Lacing of the tissue was done using diode laser with 400 micrometer fiber tip at 3-watt pulse mode. In this case, there were less post-operative problems such as pain or discomfort in addition to good hemostasis. Diode lasers can penetrate deeper and are found in the melanin absorption spectrum. The diode laser's deep thermal impact causes unintentional radiation that seals blood vessels in the surrounding tissue and may cause melanocyte migration to be delayed. Moreover, the pigment-containing cells such as melanophages, which may have gotten entrapped in the lamina propria, may absorb the diode laser. It also has a particular impact on the cells that decrease their activity. Now, in this case, a 37-year-old male patient who is systemically healthy reported with a chief complaint of bleeding gums. On clinical examination, there were generalized gingival inflammation, periodontal pocket, and bleeding on probing, thus diagnosing it as periodontitis. So for this case, scaling and root planing was done, followed by laser curettage of the tissue using diode laser. Following 2 weeks postoperatively, there was absence of inflammation, pockets, and bleeding. The most common causative factors are microbes or group of specific microorganisms, resulting in progressive destruction of periodontal ligament and alveolar bone with pocket formation, recession, or both. The conventional periodontal procedure includes scaling and root planing, which consists of debridement of contaminated root surfaces as well as elimination of bacteria and their endotoxins from the cementum and from adjacent periodontal tissue. Scaling, root planing, and curettage procedure creates a long junctional epithelium with no connective tissue attachment. When laser curettage is done in pockets, the ablating action of laser removes the epithelium lining, the soft tissue walls of the pocket, and adjacent inflammatory cell infiltrates, and the low dose radiation that scatters into the surrounding tissue possesses the beneficial effect of the healing process. The laser causes a photochemical reaction known as photobiomodulation, which induces the tissue repair and wound healing. Laser curettage also promotes the synthesis of DNA and RNA. It increases the production of proteins, modulates enzymatic activity, and affects intracellular and extracellular pH, which accelerates the cell metabolism. Studies have shown that laser curettage causes expression of multiple genes related to cellular proliferation and migration, and also induces production of cytokines and growth factors. This is a case of gingival enlargement caused by orthodontic therapy affecting a 15-year-old male patient referred from Department of Orthodontics. Additionally, it was noted that the patient could not maintain good oral hygiene. Gingiva was generally consistent and firm, with some loss of contour and stippling. It became apparent that the overall pseudopocket measured about 4 to 5 millimeters. Following initial therapy, scaling and hematological examination was carried out, and then surgical therapy was done in relation to upper anterior region. The maintenance of oral hygiene is more challenging for patients with gingival overgrowth. Hence, the therapy for gingival overgrowth is gingivectomy. So, in patients with poor oral hygiene, local stimulation of orthodontic devices, food impaction, alteration in hormonal levels can lead to inflammatory gingival swelling accompanied by compensatory proliferation of cells and collagen fiber. This can be manifested as nodular enlargement of gingival papilla. In addition, gingival hypertrophy occurs in patients with good oral hygiene, suggesting orthodontic force and periodontal remodeling associated with gingival hypertrophy. Hence, to prevent gingival hypertrophy, regular periodontal maintenance during orthodontic treatment is required. Another aesthetic concern is the persistent midline diastema in maxillary incisors. The main etiology behind it is the abnormal labial frenum. In this case, a 30-year-old female was referred from orthodontic department for correction of high papillary frenal attachment. Initially, the location of the frenum was determined by pulling the frenum. When interdental papilla moves along with the frenum, it is considered as tension test positive. Hence, a surgical procedure called frenectomy was carried out. So here, the whole thick band of fibrous tissue, including its alveolar attachment, was excised and the site was sutured. Now we can observe a favorable aesthetic outcome at the end of 1 year. That is, space closure has been achieved with lack of relapse. Midline diastema can lead to poor appearance. The presence of a wide and thick frenum attachment, which is a persistent cause of spacing between upper anterior teeth, has to be treated as it may lead to failure or relapse of orthodontic treatment. This can be corrected by frenectomy or frenotomy techniques. Here is another case scenario wherein soft tissue growth hinder the aesthetic. A 14-year-old male reported to clinic with swelling on upper left buccal mucosa since few weeks, which progressively increased to this size. The growth was pedunculated, firm and fibrotic. Following hematological examination, scaling and root cleaning was carried out, and then the growth was surgically excised under local anesthesia. Gingival overgrowth usually represents the reactive hyperplasia to dental plaque accumulation. Plaque-induced gingival enlargement usually results with proper plaque debridement. However, a small group of localized gingival enlargement may present the reactive or inflammatory hyperplasia, resulting in nodular growth that has to be histologically identified. Now, there occurs instances wherein the gingiva recedes over time. This could lead to poor aesthetic effect, sensitivity, or increased susceptibility to caries. Here's a case scenario wherein 47-year-old male patient reported to our clinic with chief complaint of sensitivity in relation to upper right back teeth region since few months. Here, the recession depth and width was about 2 mm in relation to 1/4. For this mucogingival surgical case, coronally advanced flap with connective tissue graft was employed. Here, we can appreciate that by 6 months, complete recession coverage was achieved in relation to 1/4. Mucogingival deformities are a group of conditions that affect many patients, having an impact on function and aesthetics. They can be congenital, developmental, or acquired. In this case, we try to restore ideal pink and white aesthetics where aesthetic is of prime requisite. There are various techniques with variable degree of success. A coronally advanced flap is one of the most predictable method. Now, in order to get an aesthetic smile, the two zones, namely the white that is the teeth and pink zone that is the soft tissue, should be in definitive proportion with facial profile in order to ensure an aesthetic smile. Gingival zenith point is the highest point at the junction where gingiva meets the teeth. The gingival zenith of central incisor and canine is observed distally to the long axis, whereas for lateral incisor, it is on the center of tooth. Taking this into consideration, I would like to conclude that for any aesthetic treatment, gingival health should be considered as fundamental objective in addition to its morphology and contour. Thank you one and all for giving me this patient hearing.
Pharmacy cosmetics. I have prepared nanohydrogel. These are the nanohydrogels are composed of hydrogel that is highly cross-linked with physically or chemically with the hydrophilic polymer chains. And so I have targeted on the psoriasis. Psoriasis is a chronic autoimmune skin disease characterized by the rashes with itchy and scaly patches. Herbal medicines are considered the best because of better acceptability, safety, efficacy, potency, inexpensive with the least side effects. And I have prepared for the nanoparticles by using active chemical constituents which are present in the herbal drug. And I have prepared metal nanoparticles, that is the silver nanoparticles. Need for the study. Psoriasis is a serious global problem affecting 2 to 3% of the worldwide population, characterized by the immune phenomenon. Currently available drugs for the psoriasis are associated with the side effects, and psoriasis has a significant negative impact on the patient's quality life. For these type of patients' quality life negative impact, in that some of the patients for the in COVID-19 situations, they have suicidal conditions.
Doctor?
Next one is the yes, ma'am.
Sorry to interrupt you, but would it be possible if you shared with us the presentation now so that we can present it in the...
I can't share because network issue.
Yes, but
Are
you are presenting right now, so it would be fine if you just sent it. Even if you sent it on Zoom, that would be better.
I don't have network connection with my PC, and my presentation is so that's why I have connected in my mobile.
Okay. All right.
Next one is my topic objective to carry out the phytochemical analysis by applicable parameters to design, prepare, characterize, and optimize the nanoparticles loaded herbal extract to incorporate optimized nanoparticles, nanohydrogel, in characterization, and finally pharmacological screening. Then these are the review of literature. Then methodology. That is work completed, my plant authentication, then authentication letter, then I have prepared extract, then HPTLC screening for my chemical constituents, apigenin, aloin, proanthocyanidin, then preparation of nanoparticles. For the preparation of nanoparticles, I have used 10 ml of ethanolic extract with the 90 ml of 1 millimolar solution of silver nitrate, placed in a dark light for over the night, then reduction of silver and formation of nanoparticles. Then evaluation of nanoparticles by using XRD, SAME, IR, EDS, and UV spectroscopy. These are the some chart work for the laboratory work. In case of first one is the extract nanohydrogel batches. These are the nanohydrogel batches, then nanohydrogel, HPTLC work, and that is pharmacological screening for my drug. That much. And as compared to my product, that is the comparison with the marketed preparation and my prepared nanohydrogel, that is Soriana cream having weight 20 gram, that is cost 460. Then Tazeret cream for the 20 gram, that is having 349. QT soft cream 15 gram 124, but my prepared nanohydrogel having the 15 gram only 58 rupees Indian, as per the Indian cost. That is some of the conceptual work of my topic, and that is conclusion. A nanohydrogel fortified with the Oroxylum indicum extract proves that the beneficial in the management of psoriasis and perform the in vivo study. I have already submitted for the animal ethical committee, and approval also. I get approval for the animal ethical from the animal ethical committee. Then I have targeted some of the pilot study will be designed by recruiting the human subjects suffering from the psoriasis for the determining the efficacy of the prepared nanohydrogel. Then DLQI report for the patient. It is my future plan. Some of the bibliographies references. Thank you. Hello.
Hi, thank you so much for your
on the derived mesenchymal stem cell, in a bio-cross-linked hyaluronic acid scaffold for correction, deep wrinkles, facial depression and scar, face dermis and its regeneration. This is a pilot study and the case report published in Medicina of the MDPI. Okay. Can you pass other? Okay. The aim of this clinical study is to demonstrate that through the micrograft of viable adipose tissue cells microfiltrated at 50 microns to exclude fibrous shoot and cell debris in a suspension of a cross-linked hyaluronic acid, we were able to improve visible imperfection of the dermis and to improve clinically observable wrinkles, with a beneficial effect also in the extracellular matrix. Okay. we have the section of patients and materials. The study was approved by the local ethic committee with authorization, and we tracked a total of 14 patients aged between 41 and 58 years were included in the study, but there are the inclusion criteria were the following. The first is that male or female subject between 30 years and 65 years. After the second is the presence of deep wrinkles in the facial area, around the eyes, around the mouth and cheeks, including wrinkles and spots on the face. The skin free of disease that could interfere with evaluation of the result is indispensable to abstain from any cosmetic or surgical procedure in the treatment area for the duration of the clinical investigation. After we need a written informed consent. The other exclusion criteria for this study is for family, pregnancy, absolutely, lactating, and planned pregnancy. Another reason for exclusion criteria is a history of mental disorder or emotional instability. And facial surgery or implantation of dermal filler in nasolabial region within the last 24 months. After we exclude the patients with connective autoimmune disease, as connectivitis, as lupus, and other disease of autoimmune disease. Diabetes mellitus and uncontrolled systemic disease, and the no human immunodeficiency virus positivity individual was excluded. The presence of silicone implants or implants of another non-absorbable substance as a permanent filler, as a metacrylate in the area of product application, and an history of allergies to cosmetic filling product and recurrent herpes simplex virus. We exclude the heavy smokers, major of the 20 cigarettes per day. So the detailed procedure is very simple. The study was performed by following the standard of the local ethic committee and in accordance with the Declaration of Helsinki. The patients were subjected to a subdermal injection of a suspension containing 1 ml of viable micrograft derived from adipose tissue and emulsified in a 1 ml of cross-linked hyaluronic acid as a scaffold. The adipose tissue was extracted following the protocol provided by the milligraft kit. This is a standardized protocol that guarantees the correct extraction of numerous progenitor of the stem cell, because it is essential the presence of the stem cell from the adipose tissue. In this slide, we can observe the detailed procedure. In figure A, we have hyaluronic acid pre-filling syringe and can observe the procedure to mix microfragmented fat with the hyaluronic acid. In figure B, the filtration of the collected and fragmented fat tissue. And after, we have a mixing of the fragmented adipose tissue with hyaluronic acid in a closed system to guarantee the sterility. Is a fundamental guaranteed sterility in this procedure because we have a connection of hyaluronic acid and fat of patients microfiltrated. Okay. After administering local anesthesia to the abdomen or supratrochanteric donor area with a clean solution through a 10 milliliter syringe and a 25 gauge needle, the extraction of a total of 3 ml of lipoaspirate was undertaken. The extraction with a needle allows a better survival of progenitors as a stem cell, as well as an overlap in the quantity and quality of the viable extract cell, rather than the extraction with a multi-hole cannula. We prefer the extraction with a needle, respect a multi-hole cannula, okay? After the extraction of the adipose tissue, the suspension was left to settle for 10 minutes in order to eliminate anesthesia fluid. 2 ml of adipose tissue was then processed as described by Tournard and filtrated at the 50 micron to preserve the cell population, from which about 1.2 ml of final suspension was obtained. It is known that during the disintegration and subsequent filtration, a loss of vital elements may occur. Nevertheless, by eliminating fibrous short and acellular debris, the therapeutic quality of progenitor is improved as fibrous and cell debris could activate an inflammatory process throughout the toll-like system. Okay, is fundamental, eliminated the cell debris and the fibrous, because these two point can activate an inflammatory process in the time. The microfiltrated was divided in two 1 ml syringes and added to 0.5 milliliter or hyaluronic acid through a three-way tap with a very gentle back and forward movement made 5-7 times in order to emulsify the two part. Okay, the suspension was administered through 25 gauge needle for the deep dermis and with a 30 gauge needle for more superficial treatment. Technique that we use were those of retrograde injection and micropump. The entire procedure took 45 for each patient. So in this slide, we can observe the result on the firmness and cutaneous relief. Berardesca scale for the patient satisfaction evaluation can give an important evaluation of subject of their satisfaction in comparison to D0 before treatment, after 1 day, after 80 days, and 150 days. By giving score on firmness and cutaneous relief, the scale of 0 and 4 for each criterion. 0 is unsatisfactory of patients, and 4 satisfactory of patients. The major satisfactory of patients is observable at 18 day after the treatment. About the wrinkle and the defect severity, we have the numeric rating scale evaluating defect severity and wrinkle. 10 and 0 numeric rating scale with a separate score for each side. 10 for eye wrinkle seen or eye defect severity. 5 for medium wrinkle seen or medium defect severity, and 0 low wrinkle seen or medium defect severity. This is important result of our study, the principal result. We can go. So this is an important image because these patients is an example of treatment on a patient. In the figure A, we have patients before the treatment, and in the figure B, we have patients with a treatment 18 days after treatment. Here is possible to less wrinkle, and more distension of the zygomatic area and malar area, and clear of the tissue and firmness of the tissue, major firmness of the tissue. So, in conclusion, this retrospective clinical evaluation study for the treatment of blemishes and dermal regeneration throughout a suspension of a progenitor with adult stem cell characteristics in a scaffold of a cross-linked hyaluronic acid allowed us to evaluate the excellent result obtained by the means of this method. This allows us to obtain beneficial effect on the regulation of neocollagenogenesis, neoelastogenesis, and neovasculogenesis. The processes are quick and provide extreme satisfaction for both the doctor and patients. We are sure that this new medical practice can also be used for other pathology, such as the osteoarticular pathology. But however, further studies are necessary for the moment. Okay. I conclude with this final slide because Leonardo da Vinci is my favorite artist. I am Italian, and this citation is for me the most important citation of Leonardo da Vinci. The beauty perishes in life, but is immortal only in the art. Thank you for attention, and if you want, if you have any question, I can respond you without problem.